اوكي اشتغل. يلا اوكي. في ناس داشه، انت داش؟ يلا عشان هذول الثانيين. يلا اوكي. الكاميرا بعيدة أو خلاص. هذول الناس اللي يحضروا مسؤولين بعد ما الو
حط نفسك حط نفسك زين. حط كاميران كهوست. كاميران احمد. في واحد اسمه كاميران احمد. وحطني كهوست. الحين انا كهوست. اوكي يلا خلاص يلا نتكلم. Assalamu alaikum. Good evening, everyone. It's a pleasure to have all in here, and Dr. Kamran Ahmed is joining us from London, UK, for this webinar. I hope everybody is hearing me, right?
Yes, I'm hearing you loud and clear. Yeah.
Okay. It's a pleasure to have you with us, Kamran, and thank you very much for joining us in this webinar. I hope everybody will benefit from this. And it's good to see you after a good while, my friend.
Yeah,
I hope Ramadan is easy, and I hope COVID is easing down there in London.
Yes, thank you very much. It's settling down, but still, I mean, lockdown hasn't gone away fully.
Yeah.
And there's still been a struggle, but I'm sure it'll take time.
We're in a complete lockdown here in Kuwait as well for another 2 weeks probably, or maybe less. Well, hopefully everything will settle down in a near future, inshallah. Dr. Ahmed Al-Kendari, our big brother and senior consultant from Kuwait, he joined us. He's going to be the moderator of this session. I will, I think, Dr. Al-Kendari, I'm not sure if your microphone is on. I will try to. Unmute, yeah.
ابو علي تسمعني
بتركيا؟ ايه اسمعك، نسمعك الحين، نسمعك دكتور احمد.
واضح ها؟
صوتك واضح، كلامكم بخير وتقبل الله طاعتكم جميعا.
الله يسلمك، الله يبارك فيك.
اوكي.
Dr. Kamran, how are you?
I'm very well, thank you. Thank you. How are you?
Nice to meet you. And
you likewise, thank you.
Welcome with us in this meeting. What is the time now at UK?
It's 7 o'clock.
Oh, okay, so it's not too far from us.
No, it's not.
Okay.
Okay. What time is the iftar, Dr. Kamran?
It's 8:45. It's still nearly 2 hours to go.
Okay, so hopefully we'll be finished before that.
لا لازم نخلص يعني.
Yeah. We would love to invite you for iftar in Kuwait at maybe in the future years, inshallah, without Corona at that time.
Okay? Yeah, that's a problem.
So, Dr. Al-Kendari is our moderator. I think you should guide us from now on. The schedule is Dr. Kamran will start
Okay.
I'm not sure if you want to start now or you want to wait a couple of
let's
minutes
wait.
more. It's up to you.
Is Dr. Ahmed Al-Anizi around?
Dr. Ahmed, I don't see him on the participants, but I'm sure he's going to join us now. I will contact him by phone as well to make sure he's in. So the schedule, Dr. Kamran, then myself, then Dr. Al-Anizi. Our talks will be like 15 to 20 minutes. And then I believe you have some cases to share, Dr. Al-Kendri, as well.
Yes.
And the discussion is upon your judgment to whatever you want to, however you want to run this webinar, it's your call.
Sure.
Thank you very much for everyone who's joining us.
What about the rest of the people? Can we see them there or?
So you can, in your browser, you can press on one of the no, there is like in the top right corner, there's a square and there's like little squares beside each other. If you press the little squares, you can see everyone.
I see.
Or most of the people. So for the participants, if they want to share with us their video, their picture, they're more than welcome. Unfortunately, because of security reasons and because we don't want any misuse of this, we will have to stop the chatting, and we'll stop the audio as well for everyone. Whoever has a question, please forward this to Dr. Ahmed Al-Kendri and our moderator, and he will arrange the questions accordingly.
So how many people we have now like joining us? Can you tell?
So we have so far 33 people joining us.
33 people. I think let's start and inshallah Dr. Ahmed Al-Anizi will join us. Bismillah ar-Rahman ar-Rahim. Alhamdulillah, salatu wassalamu ala Rasulullah. طبعا I'd like to thank the Kuwait Urological Association for giving us this opportunity to meet and share important topic with all of you as colleagues, and special thanks to my colleague Dr. Hussein Al-Anizi for his excellent effort to put this webinar. And also we'd like to thank Dr. Mustafa Al-Mahmid for arranging all these things, and also all the participants. My name is Ahmed Al-Kendri. I'm a urologist and associate professor at Kuwait University. It's my pleasure and honor to have with us a distinguished urologist from UK. We have Dr. Kamran Ahmed. He's an associate professor of urology, King's College London, and he's a consultant urologist of King's College Hospital London. Mr. Kamran will talk to us about the medical management of BPH. So our topic tonight is about updates in the management of benign prostatic hyperplasia. Dr. Kamran, the talk is yours, so please you can start.
Thank you. I will put it on this full screen, and let me share the screens with me. Can everybody see my screen?
No, we cannot see. How do we do that? Make the screen to be seen by the attendee.
So, Dr. Kamran, you go to share screen, and then you press, it will show you different screens that you opened. You choose the PowerPoint, and then you press share. And at that time, we will see your screen at that time.
Okay. And then it's coming up. Can you see it now?
No, unfortunately, not yet.
Okay, I'll just probably will have to change the settings. I mean, that's why it's coming up, but hopefully it'll come up. Okay.
Did you find the share screen option?
Yeah, I found it. It's just trying to go through this firewall and security.
Okay.
Hopefully it should be okay now. So. there's a firewall coming up, so that's the main issue. So
take your time.
Yeah. Can you see it now, or is still not there?
Still not there, unfortunately.
Okay, I'll try again.
So it should be a two-step thing. Probably you get a firewall, or
Yeah, that's what it's. I'm not sure about what exactly is happening. It's blocking everything. Actually, it's just the laptop probably causing the problem. So.
How is the situation while you're searching in UK?
Yeah, I mean, it's things are getting back to normal gradually. Just few of the, professions they're allowed to get back. Otherwise, the things are still going on. I mean, some kind of blockade is still there.
So still no elective cases, only emergency cases?
No, just the emergency, nothing elective so far, apart from some cancer work. So I'm struggling here, I must say that. It's just not sure if I can use something else to do that. It's just not working with my screen.
You can just speak while you're talking. I mean, it's all internet-based. Listening to you is helpful. If it works, then fine.
And maybe saying, if I forward you the link of my slides, then would you be able to run it and I can speak?
I'm not sure about that. Do you want me to start first and then you
Yeah,
follow?
I think that would be better. I can try in the meantime then, yeah.
What do you think, Dr. Kendry?
Okay, that's fine. I mean, so we apologize for this technical issue. We will start with our next speaker, Dr. Hussein Al-Nizi. He's a consultant urologist, head of urology unit in Adan Hospital. He's an urologist and robotic surgeon in Sabah Al-Ahmed and also in Adan Hospital. Dr. Hussein will give us the talk about TURP. Is it still the gold standard, Dr. Hussein?
Yeah.
And just show us how it works, because I hope it will work with me.
So should be a two-step thing. Do you see my screen?
Yes.
Yes.
Thank you. Good evening, everybody.
Who's this?
Can you hear me?
Ahmed Al-Nizi?
Assalamu alaikum. Good evening.
Yeah, good evening. We can hear you. So
Okay.
I will start my presentation if you allow me, Dr. Kendry.
Yes, you can start. Dr. Hussein Al-Nizi will start because of the technical issue. We'll have Dr. Hussein start.
Okay, until Dr. Kamran will fix this issue, I will go ahead. So good evening, everyone. I will talk about a somewhat controversial subject, TURP. I know Dr. Ahmed Kendry, our moderator, is a Holib fan, and he might argue with me a little bit about this, but I think still TURP is a gold standard. So if we look at the definition by language, what is the gold standard defined as? It's any standardized procedure or intervention that of a known validity and reliability, and which is generally taken to be the best available against which all other tests and new tests and protocols are compared. So if we go back to to history, and we see how TURP came up all the way to become the gold standard, this will take us to the early 19th century when Sir James Guthrie, a British military surgeon, came up with the idea of incising the bladder neck and small prostates instead of doing perineal prostatectomies by using blindly passed metal sound with a concealed knife, and that was in 1834. However, he did not do many cases at that time. Seviali and Mercier took this notion further, and Mercier claimed to have done 300 successful procedures using the concealed knife procedure. This was taken further and instruments improved with time. So in 1887, Bottini came up with his instrument to heat the prostate. So actually to burn a channel through the small prostate. And he claimed to have done 57 cases with 2 deaths and 12 failures. So that was not a very successful procedure. I hope everyone can hear me very well.
Yes, very well.
Okay. Until the early 20th century, when Young came up with his punch prostatectomy procedure or instrument, and this was actually the first notion of the modern TURP procedure, where you actually cutting and taking out part of the prostate by endoscopic procedure. However, this was a blind bunch, and then Fenwick came up with the idea of using loop current to actually loop cut the prostate, but this was not successful because of the electrophysiology problems. And Maximilian in 1926 was very successful in using a new radiofrequency dithermy machine to actually cut or loop cut the prostate using that procedure invented by Wobbler, or the dithermy machine invented by Wobbler. In 1930, McCarthy came up with his telescope, the new telescope, and in combination with the Stern method of loop cutting the prostate, this actually came up with what is considered the primary prototype of modern resectoscopes. So improvement in instruments and technique continued until the 1974, when Iglesias came up with his continuous flow resectoscope, which gave the surgeons the ability of continuously cutting the prostate without losing vision and without the need of a frequent emptying of the prostate. What else? In the 1980s and the early 1990s, people were more trained of doing TURPs, and they were able to take larger prostates by doing conventional TURP. So I think that's the period when TURP was announced as the gold standard. And this was very well supported by the landmark study done by Mibos et al., which was a multi-center study that included nearly 4,000 patients. That was published in 1989 in the Journal of Urology, and they showed clearly that the mortality of TURP was low at 0.2%, and the morbidity was actually low as well. So the number of TURPs for treating BPH increased steeply after that until the late 1990s, when there was very well improved medications specific for TURP or for BPH management were invented, and this medical therapy actually impacted the number of TURPs and the indications of doing TURP. So now people are shifting from doing TURP to everyone. Instead, they're doing TURP for patients who are failing medical therapy. So if we look now, what is the situation after this all? And if we look at the trends of BPH management and the world, we take some studies from the States. And if you look at this study, which was published in the Journal of Urology in 2015, that looked at the trends of utilization of laser prostatectomy and ambulatory surgical procedures for treatment of BPH from the year 2000 until 2011. They used the New York statewide planning and research system, and we can find from the graph that TURP was still in 2011 the most commonly performed procedure for treatment of BPH. If we look at the study closely, we find that there was a problem that Medicaid patients were less likely to get laser treatment than private insurance patients, which means there was a bias in offering treatment options. Also, we find that, or the authors concluded that TURP and lasers had similar complication rate, except for electrolyte disorders, which is a known inherent problem with monopolar TURP due to using glycine instead of saline. Another study that looked at the trends from 2011 until 2015, and this study was recently published in the Journal of Urology. It looked at the patients from the American College of Surgeons National Surgical Quality Improvement Program, and we can find that still in 2015, nearly 60% of patients were offered TURP or conventional TURP to treat their BPH. So TURP until 2015 was the most commonly done procedure in the States. What is the situation in Canada? I think it's the same because if we look at this survey, which included 12 training centers and 89 residents responded to the survey, we find that in regards to the centers, 100% of the centers had sets and instruments available for monopolar TURP. However, for the other procedures, we find that not even half of the centers had any of the other instruments for bipolar TURP, green laser TURP, or for HLIB or other procedures. What about the exposures by resident? We can see clearly from this graph that most of the residents actually were very well exposed to doing monopolar TURP by assisting, performing, or seeing. However, for the other procedures, the situation was very different and it wasn't promising. Although we know that one of the pioneers of doing HLIBs in that situation and who started HLIBs and actually modified the techniques of HLIB was Dr. Mustafa Al-Hilali from Montreal in Canada, but that did not affect the situation in Canada. So what about in Kuwait? I think we have, I'm not sure about the number, but we have nearly 100 qualified urologists in Kuwait. How many are doing routine TURPs? I'm not sure. I know Dr. Al-Kendri is doing routine TURPs, but I'm not sure about anyone who's doing routinely TURP. I know that some other doctors are planning or are actually training on doing HLIBs. And this is a trend now, as we notice in social media and by talking to our friends, that many people are actually trying to move to doing HLIBs, but still TURP is the mostly commonly done procedure. What about outcome comparison of BPH surgical intervention? If we look at this meta-analysis or very famous meta-analysis that was published in 2010 in European Urology, that included 27 studies from 1997 until 2009, and there was 23 randomized control trial in that meta-analysis to assess the functional outcomes of cone BPH treatment and comparing them to TURP. We can see here from this diagram that the most wide or most commonly done procedure was actually monopolar TURP, and the second most commonly done procedure was bipolar TURP. So we can see the vast difference between the TURP and the other procedure. And if we look at the functional outcomes, we find that in IPSS score, quality of life, QMAX and PVR, they were all comparable between all the procedures, between lasers and between conventional TURP. Some of them were actually in favor of TURP more than other procedures or lasers. If we look at those tables. I'm not asking you to read all of this, but this will show us the perioperative complications, late complications as well. And when we look at those, believe me, there were comparable safety profiles to all the procedures. Maybe there was a trend toward lower overall complication rate using bipolar TURP, but the authors concluded that this meta-analysis demonstrate statistically comparable efficacy and morbidity for the missed procedure versus temporary TURP. So there was no difference. Another recent meta-analysis and the systematic review that was recently published in World Journal of Urology, which looked at or compared between lasers and bipolar technology by Go et al. This included 27 patients, and this was included studies up to the year 2018. And the authors concluded that early efficacy and safety profiles were comparable between lasers and bipolar technology. However, lasers were superior in terms of smaller hemoglobin reduction, but this did not translate into a better transfusion rate. Lasers were actually better in shorter catheterization time and shorter hospital stay. But when we look at the studies or the meta-analysis, the difference was only few hours. So what I think is better to serve patients, we should actually improve our TURP outcomes. How we can do that? Probably by using bipolar technology instead of the monopolar technology, because we know that it is the same technique with the same efficiency and outcomes. However, there is a proved reduced morbidity by using the bipolar technology because we're not using glycine, so there is no TR syndrome at all. There is a approved less blood transfusion, less clot retention, and less urethral stricture in the cases of bipolar when compared with monopolar TURP. Another technique to improve TURP outcomes, I know that now in the era of new technologies for BPH treatment, everybody is talking about retrograde ejaculation. So how can we serve our patients better with TURP? Probably by doing ejaculation preserving techniques. This has been published since 2014 by Lucy et al. In the Journal of Urology, and there's a more recent study by Gill et al. They proved that this technique might actually be successful in nearly 90% of antegrade of patients accomplishing antegrade ejaculation. Also in those procedures, they proved that by preserving antegrade ejaculation, they actually improved voiding parameters significantly. Finally, when we look at the new technologies, I know Dr. Ahmed Al-Anizi will talk about new technologies, and they do have a role in BPH treatment. However, all recent studies, when we look at them, they actually compare their new technologies to TURP, which is the gold standard. And this is our argument today, that TURP is still the gold standard. So all new studies are actually comparing new technologies to the gold standard, which is TURP. Guidelines, the European guidelines still state that transurethral section of the prostate is the current standard surgical procedure for men with prostate sizes of 30 to 80 mL and bothersome moderate to severe lots secondary to PBO. What about the American guidelines? They clearly state that TURP remains historical standard by which all other subsequent surgical approaches and treatments for BPH are compared and serves as the reference group for the other techniques in this guideline. So still, according to both the European and the American guidelines, TURP is still the gold standard. So if we go back to our slide from the start and about language, TURP does fulfill the criteria to be the gold standard for BPH management, as TURP is a standardized procedure with known validity and reproducibility and reliable outcomes. and still TRP is compared to all new technologies when we want to prove that new technologies are actually working. I think I will conclude in this page. Thank you very much for your attention.
Thank you.
Thank you very much, Dr. Hussein Al-Nizi, for this very thorough and concise summary of history and recent recommendations for TURP. I just want to ask a question. Since we are in Kuwait and we have residents, how easy it's to train residents to do TURP in your hospital, or because the number of cases are not as we expect to train. So just if you want to train them on TURP, what's your advice to help them go through this?
So as you said, the problem is the number of TURPs performed nowadays because of the effective medical treatment. This actually has delayed the management, the surgical management of BPH patients. So now we're seeing more of older patients requiring TURPs. Instead of having their TURPs in the 70s, they're requiring their TURPs in the 80s and 90s even. So that will affect to some extent the perioperative morbidity to the patient. The number and the quality of patients might have an effect on training, but however, I think if you start training the residents from R3 or R4 and their like early senior resident years, they will actually be able to do TURPs. And you have to have a system in training them. So actually, if you start by those years by giving them few cuts and by showing them how to go systematically and doing TURPs, I think by the end of R5 they will be very, very well trained in doing their TURPs. I think that's the way. Being involved in every TURP patient or every TURP procedure is also a goal, because as we said, the number of patients is not that huge these days, and that's something that we cannot do anything about.
Yeah, it's very interesting. Thank you so much, Dr. Hussein. Is
you.
Dr. Kamran ready, or should we go to the...
I have changed the laptop to Windows, and let's see whether this works.
Is it working now?
Yeah, I've changed my laptop now, so let's see if it works. So you just
would like to طبعا نرحب بدكتور احمد العنزي. ابو محمد مساك الله بالخير.
الله بالنور والايمان.
شلونك؟ شو اخبارك؟
الله يحفظك. بارك عليك.
من الشهر وفرصه اللي شفناك، يعني هذا من فوائد النشاط هذا ان ابو علي ابو تركي خلانا نشوفك يعني.
حبيب قلبي يا ابو حمد، حبيب قلبي.
الله يخليك. Okay, so now it's our pleasure to have with us Dr. Kamran Ahmed. He's a consultant urologist from King's College Hospital in London. He will talk about the medical management of BPH. Dr. Kamran, you can start, please.
Okay, can you see the screen now?
Yes, we can.
Yeah, we can.
Okay, so it means Windows is more reliable than the Mac.
Yeah, always stick with Windows.
Okay, thank you very much for asking me to give this talk. It's basically all about medical management, and prior to medical management, I thought I would include some basics of prostate enlargement, its investigations, some natural history, and what the progression is like. So I haven't got any conflict of interest. So first starting with the basics of prostate, like zonal anatomy, what part of the prostate is involved. I've got a few definitions to share as well. And then I'll go through the general medical treatment. So this is prostate, different zones are there. We are all familiar about these zones. It's just reiterating that this is the transitional zone that basically when it gets enlarged, it causes the symptoms. It enlarges with age. And then as you can see around the urethra, encompasses it. When it gets bigger, not only gets bigger towards outside, but also towards inside. Thus we get all the symptoms. Certain definitions, I would say, we're all familiar with the term lower urinary tract symptoms. It's a non-specific term for symptoms, which is attributed to a number of causes related to storage and voiding. BPE is a clinical finding, which is basically, we can say, histological finding, enlargement or due to hyperplasia of the prostatic tissue, and then bladder outflow
I
obstruction.
cannot see the screen.
Can you see the screen now?
Actually, it's frozen to the first slide, so if I'm not sure why it's not advancing.
No,
Can you see now?
I cannot see it. Can you guys
It's
see
still
it?
the same page, yes.
It's the same page coming up. Okay.
No, well, actually, it's on the side. Yeah, now it's, yes.
Yeah,
You
now
can see now.
Oh, yes.
now it's moving. Yes.
It's okay now, yeah?
Yeah.
Okay. So, yeah, this is what, can you see the slides with a few definitions now?
Yes, but
Yes. So
Okay.
when you
how
see the
about
side
if you put it in the
center,
show mode? So I think you're still having the slides on the side. So
So show mode is not coming up. Okay. That
okay.
makes sense. Okay.
It's okay as long as you can proceed. It's okay. شو رأيك بتركي?
yeah, sure. If it's not coming up, so continue.
I'll go to
have
here, then that's no problem. So, so that's this is what I was mentioning about LUTS, BPE, and bladder outflow obstruction. Then, as you can see, LUTS can be because of any of these reasons. I've taken this figure from EAU guidelines book. So, what we are talking about here is the benign prostatic obstruction related to BPE. And then clinical BPE is BPH describes the histological basis of benign prostatic enlargement, and that results in bladder outflow obstruction, and it gives rise to low urinary tract symptoms. That's we all familiar about. I just thought is to reiterate all these. Health is a consensus statement that was described in late 90s. As you can see here, when enlargement of prostate takes place, low urinary tract symptoms bladder outflow obstruction. So for medical treatment, this yellow part that you can see amongst these three circles is the basic thing that actually requires some kind of treatment, medical or surgical treatment. So we're targeting this group which has got bothersome low urinary tract symptoms. The other group that lie within these circles outside, they can mostly be managed with wait and see or conservative measurement options. Different risk factors are there. With age, the risk increases, and androgens, and I mean, whenever they increase in amount, the risk is there. It results in growth of the prostate. Certain systemic conditions like obesity, diabetes, dyslipidemia can increase the risk of low urinary tract symptoms because they cause systemic effect. They alter the metabolism, so that's why sometimes the prostate gets bigger earlier, or the associated features take place. Symptoms of BPH could be voiding related or storage related. Voiding is when it's an active process, and most of it is in the storage phase. So whenever these symptoms are related to the voiding, can result in hesitancy, takes time to start urination, intermittent weakening in streams. And that's what people complain of. But people, when they come in with associated symptoms because obstruction occurs over the passage of time, and that results in storage symptoms as well. So it's a combination of the system, and careful history would just like tell us how to differentiate between these two. This is a very important slide. I would say that we can use this slide to explain it to the patients about the prevalence. So prevalence is presence of a disease at any point of time in a population, and that is, as you can see, below 30, the risk is actually prevalence is 0%. 40 to 49, up to 14% of people can have BPH-related symptoms, and above 70, above 79, up to 40%. So overall prevalence is 25%, and above 40, up to 70 or 80 years of age. Sorry, my phone's ringing. Yeah, can you hear me?
Yes.
Okay, yeah. And then coming to the natural history of the prostate, there are a few landmark studies which has been described in the literature, and most of the studies have actually been initiated and completed within 1990s, but some of them have extended up to early 2004 or 5. And this is the results we are all relying on. That's how we describe the natural history of BPH. The main studies were Onset County study, a Canadian study, and then MTOP study. So Onset County study is a longitudinal study that was done in 1990, and the follow-up was for 12 years and included more than 2,000 patients with years. And progression of BPH within this study based on the data was defined by deterioration of IPSS or AUS, by deterioration of quality of life, maximum urine flow, prostate volume, and acute urinary retention. So there are certain numbers here. As you can see, volume 30 to 40 ml suggests progression. PSA increase is above 1.4 or 1.6, again suggests progression. IPSS score, any increase in IPSS score above 0.18 points per year is again a sign of a progression, and so is the Qmax increase 2.1% per year. That means 0.2 ml per year. And the prostate growth, if it's 2% per year, that's again a progression. And probability of acute urinary retention, if someone's in 50s with these symptoms and enlargement symptoms, it's 1 in 100. Someone's above 70 is 1 in 10, and above 80 is 1 in 3. So that kind of significant all these numbers have. So that's crucial that when we are managing these patients, either expectantly or through medical management options, we need to know all these numbers. Then again, a relative risk of acute urinary retention, the way how it increases, I mean, is if IPSS is more than 7 or less than 7, 3 times difference, then trust volume. I mean, this is how mostly we evaluate the volume of the prostate. Other option is MRI, and the Qmax, BVR, and PSA. You can see the range is between 3 to 4% increase by changing certain numbers up there. Coming to the assessment, I'll just put this details over here from the EAU guidelines. I don't have to go into the details, but it's important that whenever we're assessing a patient, complete history regarding the voiding and the storage symptoms should be taken. I'm not putting this into the slide mode because it comes up with you won't be able to see. That's why just going through one by one. So then IPSS scoring sheet is really important. Prior to a patient coming to the clinic, the patient should have IPSS scoring sheet. An IPSS scoring sheet has been translated across different languages and validated. And the flow rate evaluation, some clinics send it to them prior to this clinic, or sometimes they take it home with us and do it for 3 days. That is a frequency volume chart. And then evaluation of prostate size, digital rectal examination, and urine dip is important to make sure there's no infection or hematuria, microscopic hematuria. PSA, I mean, PSA is an area that people tread very carefully, evaluating the PSA, and it's well documented. It should be an informed decision and should be done after counseling. But as you can see, the reason why I showed you these progression studies in the previous few slides regarding the natural history, because PSA is an important in order to evaluate the progression. So these patients, in my opinion, should have PSA, but with the counseling. And then renal functions, which include creatinine, eGFR, to make sure that renal tract's okay. And if there is any kind of abnormality within that, then proceed to an ultrasound scan of the kidney and the bladder to make sure that's all okay and there's no blockage because of the prostate. And the uroflowmetry is mandatory for these patients. They should have it because that not only gives us the voided volume estimation, it gives us a Qmax and gives us a residual volume. And then cystoscopy only indicated if someone's coming in with hematuria, persistent microscopic hematuria, or if there is a previous history of prostate treatment, endoscopic treatment to rule out any kind of stricture. It's an overview of IPSS. I'm sure everyone uses that. And then a few facts about urine flow rate. Urine flow rate is affected significantly by age. This is what I put in up here. In males, if less than 40 is 21 ml per second. 40 to 60 should be more than 18 ml per second. Above 60, more than 13 ml per second is accepted. And within females, I mean, just in female group, I mean, you can see 25 and 18 is the cutoff. So age and sex, they are just obviously significant determining factors. Voided volumes, I mean, for the flow rate evaluation, it should be more than 150 ml in order to have a reliable test. If it's not more than 50 ml, we just have to repeat it again. And then it actually determines bladder outflow obstruction and overactivity by just looking at the graph pattern. And with regards to obstruction, 99% of probability obstruction is there if the Qmax is less than 10 ml per second. So this is, you can see how important this test is. And then 60% probability if it's between 10 and 15, and 30% if it's more than 15 ml per second. But I mean, these days, if we repeat these flow rate evaluation twice, and this figure even comes down to 10 to 15 even, but this is based on the old study. So that's why, I mean, we just have to quote this. Then coming to the pressure flow study, I won't take too much time here. This basically, this is the only study, the urodynamics is the only study that can actually differentiate between the obstruction and the obtrusive activity. And the indications are quite a few with regards to this. The voided volume is less than 150 ml.
Dr. Kamran, I'm sorry to interrupt you, but if we can go a little bit faster. So
yeah, coming through. So that's 150 ml for voided volume. And then if there are certain indication, I won't go through just to save the time here. Then coming to the management, actual thing that we were going to discuss is that includes watchful waiting and pharmacotherapy. So watchful waiting is for someone who have got mild or non-bothersome low urinary tract symptoms, and that's all based on IPSS scoring. So first line treatment for these patients is lifestyle modification. Fluid restriction, I typically say to my patients to avoid taking fluid at least 2 hours prior to going to the bed, and then irritating fluids that irritate the bladder, like alcohol or caffeine, should be avoided. Drugs should be monitored. I mean, you can ask the lifestyle changes, like ask the patients to take the diuretic in the morning, and they all can be changed. And then constipation and elderly, important factor to manage. Bladder training and retraining, time voided, double voiding, all these things do matter. And then the pelvic floor exercises. And before starting the medical therapy, I would say phytotherapy is an alternative treatment that may possibly work because of anti-inflammatory effects, bisulfite inhibition that reduces 5-HT, and then interference with the growth factors. So that's how it works. The soft palmetto has got, I mean, is one of the extract that's mostly studies, but most recent Cochrane review that was done in 2012, which included 32 trials, it actually did not show any improvement in urinary fluid measurement or prostate size with this. However, the study done in 2004 by Boyle, that actually showed improvement in the peak flow. There's a variable evidence, but we're mostly relying on the Cochrane review. So this is mostly for those patients who don't want to go for the medical treatment in order to avoid the side effects. So this can be considered for this group of patients. Coming to the medical therapy, I would only talk about 4 main groups. Alpha blockers, 5-alpha reductase inhibitors, 5-PDE5, and some combination therapy. So I would go through these bit by bit, and then I will also explain the evidence behind it. So alpha blockers, which relax the smooth muscles around the prostate area, around the bladder neck, and they are long-term effective treatment. So alpha blockers, uroselective alpha blockers are actually available now, which target 1A receptors that include tamsulosin and amphicillin, and there are also non-selective alpha blockers that result in overall alpha blockade, like doxazosin and terazosin. And they improve IPSS actually rapidly. Within few days, patients will tell you whether there's a difference or no difference. The adverse events of these two groups, that is 1A and 1-alpha blockade, differs because terazosin and doxazosin can have, because of the effect and duration, cause most dizziness and fatigue and asthenia. So tamsulosin, it doesn't cause these symptoms, but it results in ejaculatory disturbances in about 10 to 20% of patients. But these 2 points are important to remember, that none of the alpha blockers, they change the prostate volume or PSA, and none of the alpha blockers change the natural history or progression of the prostate diseases. So that things are important. They are there for long term to improve the symptoms. So just put this slide here to show different receptors. Actually, prostatic alpha 1A receptors, blue color, are there around the prostate and the bladder neck. So that's where the tamsulosin has got the effect. Where the red ones up here, around here, that's where a whole of the alpha blockade takes place. So that's why when the whole of the alpha blockade takes place, you will get more side effects. So that's why we should keep this in mind when treating these patients. This graph shows that when alfuzosin or tamsulosin started in patients with IPSS around this range 9 to 11, it drops immediately. Tamsulosin affects rapidly than the alfuzosin in the beginning, but the long term, after 12 weeks, the effect or improvement in the symptoms is mostly the same. So the side effects mainly that we talk about to the patient, specifically tamsulosin and alpha-1 receptor, nasal congestion, drop in the blood pressure, that's orthostatic, some degree of dizziness or tiredness when they started, so that's why we ask them to take it in the evening mostly, and then ejaculatory problems and retrograde ejaculation is being reported with these drugs as well. And then next one is intraoperative floppy iris syndrome, which is not very common, but it can occur with tamsulosin. And people, so the careful history is important, especially people with complicated cataract surgery. This one should be. I think this one should be. We should be careful in giving this. So then coming to 5-alpha reductase inhibitors, so that they actually reduce the dihydrotestosterone that reduces the growth of the prostate. And then coming to 5-alpha reductase inhibitors details, so they overall shrink the prostate size and they limit the clinical progression of the prostate. So that's why, I mean, you can see the natural history of the prostate is changed over here. And then minimal effect for these medications up to 3 to 6 months, as compared to the tamsulosin effect. You can see alpha reductase inhibitors can take up to 3 months to show some effect in improvement in the symptoms. So they don't act that rapidly. 5-alpha reductase, as you can see, limit the progression, improve the flow rate, and IPSS, and then they're more noticeable in patients with a larger prostate, above 30 or 40 grams of the volume in the prostate that are smaller. They're not going to affect that effectively in these kind of patients. And then 2 different types of alpha reductase inhibitors we commonly use, dutasteride, finasteride, and there's not much difference between these 2 medications effectiveness. That's why I've just put this slide here. Then coming to the evidence, so PROSCA long-term efficacy and safety study, the one that has is been well quoted, and it's a one of the largest study with more than 3,000 patients over 4 years. And this study uses 5 milligrams of finasteride with placebo. The outcome of this study was that it actually reduced the relative risk up to 55% with BPH surgery and 57% of development of acute urinary reduction in these patients. And you can see clearly in this graph over here. And this is an advantage of, as you can see, the finasteride overall changing the natural history of the condition. That's another evidence that's the PROAS study, that again, more than 3,000 finasteride over 2 years. And a similar kind of results, 40% relative risk reduction in the BPH surgery and 55% in development of acute urinary retention in this study. So these 2 are important pieces of evidence to show that finasteride or dutasteride, they reduce the risk of BPH surgery and reduce the risk of AUR. And then there's another study with more or less the similar kind of results. And coming to clinical efficacy of these 2 different drugs, as you can see, overall, they're more or less the same. So this is 48-month study, and this one's 24-month study. So volume changes do take place, IPS improves, and the volume changes with both of them on average. We can put this to the patient that overall prostate volume can reduce or it can shrink from 20 to 25%. And then improvement in IPSS and then maximum flow rate is noticed as well over the period of time. And then this is what I've already mentioned in the previous slide, reduction of risk. The side effects of these medications sometimes are intolerable for the patient, especially for the younger patient who tend not to give it to them because it results in reduced libido, erectile dysfunction because of the type of mechanism of action, and ejaculatory disorders. And if patients report gynecomastia or breast tenderness, then it has to be stopped and it's all reversible. Then coming to some evidence around combination therapy, which is a combination of alpha blocker and 5-alpha reductase inhibitors. So that's the first trial that comes to our mind to prove the effectiveness of this kind of thing is AMTOP trial study. That's medical therapy for prostate symptoms. So this study recruited more than 3,000 patients with a mean follow-up for around 4.5 years, and mean AUA or IPSS score in these patients was 17 and prostate volume was 37. So the final results out of this study show that if the combination is used, then the reduction in overall clinical BPH progression is 66%. If we use the drugs individually, either alpha blocker or 5-alpha reductase inhibitor, the range is between 34 to 39%. So overall combination in patients who have got low urinary tract symptoms, enlarged prostate, raised IPSS of more than 1.4, the combination can be helpful. And then reduction in risk of acute urinary retention and surgery is there. With the combination, you can see is 80% reduction in acute urinary retention and around 70% reduction in surgery. So that is an important study that shows establishing the evidence of combination. Few graphs, as you can see, combination therapy actually improves the overall risks here. Again, acute urinary retention risk is reduced over here as well. And then combination reduces the risk of BPH, need for BPH surgery as well. So another
conclude, Dr.
study establishing. I've got a few more slides. Is that all right?
Yeah, okay.
So COMPACT study, again, is just like establishes the tamsulosin effectiveness here. I'll move on from this one. And then a couple of important slides on ALPHO study. At ALPHO study, I'll take you to this diagram here. So if someone coming with acute retention and starting an alpha blocker, then trial of removal of catheter is given, it means that it improves the effectiveness and it improves the success of a trial. If again, this alpha blockers continue in these patients, actually it reduces the need for future surgery. And then PDE5 inhibitors, which are again mechanism of action, we know that they cause dilatation of the vessels and improve the flow. Here is the most important slide. I would say the PDE5 inhibitors like Prostantic and Tadalafil improve the IPSS and they improve the IAEF score. So actually patients coming with both symptoms, ED and LUTS, they can definitely benefit from these medications. Regular use, daily low dose use of these medications have proven their effectiveness. So finally, I would say that it's important to take the complete history, know the parameters that are there in the natural history or progression trials, and then we can treat these patients successfully before they are required any kind of surgical treatment. Thank you very much.
Thank you very much, Mr. Kamran, and I apologize for rushing you.
That's all right.
I know, I mean, it's a very thorough and very complete lecture, and it's very helpful. I just have a question. You did not include the anticholinergics in your treatment armamentarium for BPH-related symptoms. So what is your advice generally? When should you give or not give? Just a quick review on that.
I mean, I did not include anticholinergics is because I was just talking about the prostate. Yeah. So anticholinergics, obviously, they have got action on the bladder, and most of these people develop bladder dysfunction. So if the trials of tamsulosin and dutasteride, they're not working, the anticholinergics can be added. There are certain combination of these drugs that are there. Specifically anticholinergics, I would like to add them if someone has got a urodynamics evaluation and they have got equivocal results. So, I mean, that's another way of adding them, but they have got important, role in managing the bladder dysfunction or overactivity of bladder, which develops as a result of obstruction.
Okay, what about the role of anti-diuretic hormone in patients with nocturia and BPH symptoms? I mean, they're bothered with nocturia. I know the problem with hyponatremia, etc. But do you believe they have a role in select patients?
I mean, certainly. I mean, that's why, I put in this slide earlier that showing different kind of modalities that can cause lower urinary tract symptoms. I mean, most of these patients, when they come in with the prostate-related problems, we treat them around this kind of provisional diagnosis, because most of us, we do not do any kind of objective investigation that is actually the urodynamics, unless we give them a trial. So I think that's a step-by-step way. And if there is, after the bladder diary or frequency volume chart, if there's something that's showing this, and the prostate is not enlarged and not causing problem, I would straight away move on to treat nocturnal polyuria.
Okay, that sounds very interesting. Thank you so much, Dr. Kamran. And we'd like to finish up with Dr. Ahmed Al-Anizi. Dr. Ahmed Al-Anizi is a consultant urologist, robotic surgeon from Mubarak Al-Kabir, and also Sabah Al-Ahmed Center. Hayyak Allah, Abu Muhammad. So your talk will be about minimally invasive surgery for BPH. So give us something minimally invasive. We can't hear you. Did you hear us, Ahmed?
Can you hear me?
Yes, yes.
Okay, I think I was muted, but I'm back. Let me just see if I can share the screen.
Dr. Kamran, we should invite you for Futur here in Kuwait. So
anytime, yeah. Let the COVID settle down.
So thank you very much, Dr. Kamran, for this informative talk. I think you have to unshare before Dr. Ahmed can actually share his his slides.
Okay, so I will.
So you can see up stop sharing, like up on the screen on your side.
I've done it. Pause sharing and then stop share. Yeah, I've done it.
Stop share. Yeah. So now Dr. Ahmed Al-Anizi will be able to share his slide actually.
Okay.
عندك ربع ساعة أبو محمد ها؟
إن شاء الله. How can I share it? Just click what? Share screen?
So share screen, then it will show whatever screens are open. Yeah, great. So now if you put it on the slideshow mode from your side.
Okay.
So just if you're doing any presentation, Joe, go to the slide.
Can you see it now?
Yeah, great. Thank you.
Yeah. And you can hear me well, huh?
Great. Go ahead.
Great. Good evening. Nice to meet you all. Welcome, Dr. Kamran. We're very happy to be connected with you. We've always been fan of your work as well. So I will be talking about minimal invasive procedures for BPH. And let's see, the first slide. Okay, so the map of the talk, I will be talking about background on BPH. I will not dwell on details about it. I think both of you did a great job in elaborating over this. I will be just touching base on international guidelines, outcome, and cost and decision making. I'll be mainly focusing on Resume. We've started Resume as a minimal invasive therapy in Kuwait in December, and then we were hit shortly in 2 months afterward by this COVID-19. So everybody has been on hold since then. How big is the prostate? As we all know, as we age, the prostate tends to get bigger and bigger as we age. And the normal size is the size of a walnut. And then some patients may actually have a progression of their prostate size, and they can become as a ping pong, which is roughly a 30 to 35 gram, which is the size of that prostate. And then some group of patients will develop to a huge and bigger prostate, like the size of a tangerine. So regarding BPH, why do we need to know about it and how important it is? It is one of the most common diseases in aging group. Older age is a risk factor for clinical BPH, as you all know, and the prostate volume increases with age. And definitely now we are more aware of obesity as a risk for BPH surgery. and urinary symptoms progression, as well as initiation for BPH medical therapy. In addition, diabetes have been associated with increased prostate size, lower urinary tract symptoms, and the need for BPH surgery down the line. A few more points about BPH. There is definitely overwhelming evidence to support coexistence of erectile dysfunction with LUTS, and 50% of men below 60 years undergoing surgery for BPH had a heritable form of disease. And in addition, decreased physical activity and exercise have been linked to increased risk of LUTS and BPH surgery. As we all know from our practice as well, medications can produce unsatisfactory symptom relief and associated with troublesome side effects. And around roughly 1/3 of these patients with moderate to severe symptomatic BPH are on continuous drug therapy for the rest of their life. What sort of symptoms? We are guided by our clinical history in terms of the obstructive symptoms. Also, our management and investigation is guided by the obstructive, irritative, and the symptoms of complication of BPH. We also rely on IPSS directly and indirectly by taking the history, and directly by actually going through the form itself to quantify the patient's symptoms, as well as to ascertain their quality of life in terms of the BPH score. Our management tends to go through observation versus dietary supplements. Then we might go to medications if the symptoms are moderate to severe. Later on, we would consider definitive surgery, such as TURP, which is the gold standard, holmium laser or green laser, and recently emerging thulium. And now we have more tendencies that we have subgroup of patients who might benefit from alternative medical therapy to medications, or as a bridge to surgery if needed. And some of these, like TUMT and tuna, have faded away because of their complications, and also because of the uptake of these procedures. And more or less, we're left with two minimal invasive surgeries, such as Resume and Euro left. Side effects of medication. Let me just take a second. Side effects of alpha blockers that we tend to use. We all know that it can cause abnormal ejaculation, decreased amount of semen, low blood pressure, dizziness, headache, and blurred vision. Moreover, 5-alpha reductase inhibitors such as finasteride or dutasteride, they can cause impotence, trouble having orgasm, abnormal ejaculation, swellings of the hands and feet, swelling and tenderness of the breast, dizziness and weakness. Moving to the standard surgical treatment, which is TURP. We all love this procedure, and we all more or less practice it. However, because of certain limitations of TURP, such as retreatment rate around 1 to 2%, depending on the data that you tend to review, as well as complications, retrograde ejaculations around 65%, and maybe it can reach up to 85%, erectile dysfunction, give and take, around 10%, urethral stricture, urinary tract infections, bleeding, and urinary incontinence, whether it is urge incontinence or stress incontinence. So TURP also requires the use of general or spinal anesthesia and carries a hospital stay of around 2 to 3 days. Hence, we all move to searching for new other modalities, such as in a way as an alternative strategies for TURP. So Resume is one of these minimal invasive procedures. We have, as I outlined earlier, we've introduced this to Kuwait in December. And Resume relies on the use of radiofrequency energy, which produces water vapor stream. And the ultimate aim is to cause tissue necrosis at the transitional zone of the prostate. It has gained FDA approval in 2015, and it has the advantage that it can be used on median lobe. And as you all know, median lobe can be very challenging to us as urologists, because we have a subgroup of patients who have who are refractory to medical therapy because of this median lobe. So in a way, it can be used as an alternative to medical treatment for those subgroup of patients. And this is how the gadget looks like, and how the water steam comes out of the end of it. And this is just a quick view how the gadget itself, the resume arm, how does it look like inside the urethra on the way to the bladder, and you can see the prostatic lobes in between. So how does it work? Just to give a flavor of our audience, it utilizes water vapor, which is delivered through a retractable vapor needle via emitter holes in the transurethral device. Around 9 seconds bursts are used into in the transition zone of the prostate, and we utilize convection as opposed to conduction. And convection is literally when you try to boil water and you get the steam, but instead of using the fire below, we are actually relying on the steam itself to transmit heat. And this thermal therapy, or this form of water vapor, diffuses evenly through the target tissue, and the depth of the needle is around 10 millimeter, and the contact body temperature tissue allows the water vapor to condense within the tissues of the prostate, eventually triggering cell necrosis. In addition, overlapping injection can be utilized and can be applied to the fully targeted area of the hypertrophied part of the prostate. We utilize a saline flush through this gadget that I showed you earlier to cool the urethra, and the majority of patients can be done either with oral sedation only, or one of these patients, one out of 5 of patients may require prostatic blocks, and 10 to 20% require intravenous sedation. So in a way, this is a very nice alternative modality because you can use it as a day case. According to the published literature, greatest improvements tends to be seen 1 month. From my just personal experience, when we did the first 23 cases, I would say probably I would allow up to even 6 weeks before you would actually see the first sign of improvements. The advantage of resume therapy is it has no causes of ejaculatory or sexual dysfunction, although there have been reports that it can actually reduce loss of seminal volume in around 3%. I'll come to that later. And possibly there are some subjective improvement in ejaculatory and sexual function by around 30%. So some patients are actually reporting, despite having an IEF-5 or the SHIM score, which did not show much change of a baseline, but 30% of these patients, they report improvement at a subjective level. And there's certainly significant symptomatic relief of LUTS when you compare it to baseline medication. There are emerging data which now tends to actually break the boundaries. Our level initially upon the recommendation of the FDA and the NICE guidelines and the Canadian guidelines is to use resume for patients with a prostates more than 30 and less than 80 grams. But now there are emerging data from abstracts that have been submitted to international conferences lately that it can be utilized in urinary retention and in patients in home care, and it has been utilized in patients with a prostate around 90 grams and maybe up to 100, but nothing more than that. The lovely part about this procedure, while Dr. Hussein is doing a TURP, a lovely TURP over 60 minutes, I can do maybe 6 or 10 resume in that list.
And get more money, huh?
I'm not too sure about that, but that's the beauty of resume. So there's
it's worth it. And if they fail, you do TURP with Dr. Hussein again.
Yeah. So the lovely part of this, you actually feel a sense of achievement. You're doing more cases. And as I said, you can do a high number of procedures. So Resume has the advantage of targeting also median loop, which you tend not to be able to actually get a satisfactory outcome with patients who are treating medically with it. And there is a benefit of cost saving in terms of decreased hospital stay. One of the downsides of this Resume, and you have to counsel these patients really, really well. Otherwise, they might just turn them back and maybe go to Dr. Hussein and have their TURP done. So you have to convince them that they need this Foley catheter for 4 to 5 days. I managed with my counseling to actually have it, make them have it for 7 days. And I will tell you why I actually did this. And you may consider prior flexible cystoscopy, as Dr. Kamran nicely showed, that depending on your clinical history, if the patient has hematuria, previous surgery, or if you're not too sure about the diagnosis, you will definitely combine flexible cystoscopy beforehand. This is how the images look like. This is a median loop that you can see because of an enlarged prostate. And look at 6 months later, how the urethra is well and patent around the bladder neck. And this prostate size was around 50 grams. One of the limitations that we have is the evidence-based. We only have until this date is one randomized trial, and this has been reviewed and edited lately in around April in 2019, and we managed to actually scrutinize the outcome of Resume over 4 years period. Our colleagues in Canada have actually included it in their guidelines. They have endorsed it with very standardized and also meticulous criteria. And as I said, we have to compare apples with apples. Resume should not be compared with TURP. TURP remains the gold standard, and this is just another option that patients can utilize. Nice guidelines from the UK, and this has been also endorsed and with recommendation about how to use it. More or less, the American Urological Association, the Canadian Urological Association, the NICE guidelines, they fit together in terms of the recommendations. So I'll be moving about now more or less comparing, just move on, just to compare, to show you just some outcomes. And this is our level of evidence. Uroleft, for example, has 5 years experience with 2 RCTs, Resume 1 RCT, 3, now 4 years experience. HOLEP and PVP, we have up to 20 years with randomized trials, more than 30. So let's just talk about outcomes and let's compare them head to head. I haven't included TURP because, as I said, I still consider it, a different entity and different modality and should not be compared. But let's just have a flavor how things look like when you compare Uroleft and Resume and HOLEP. So, beg your pardon. So here, for example, the IPSS has improved significantly after 3 months, more or less head to head with Uroleft is similar. After 12 months, you have more sustainable improvement of IPSS. Definitely HOLEP and PVP tends to be higher, and we know this for a fact because you are actually inoculating the prostate or vaporizing the prostate, so you won't have any residual tissues. And the long-term outcome after 36 months, improvement in IPSS by 11 points. In terms of the Butler score, again, Resume and Uroleft more or less similar, and at 12 months, they both sustained it really well. HOLEP tends to be much better, of course, and the long term has been more or less better after 12 months in terms of the improvement of the Butler score. What about the Euroflow, the Qmax? We tend to be dragged on a lot about how the Qmax look like. It feels as much better, but I have discovered actually from the set of patients that I've operated on, that you may have marginal improvement of Qmax, but tremendous change in IPSS and Butler score. But let's more or less look at the data here. The baseline of the Resume was around, and Uroleft around 10, so slightly more advantageous for Resume. At 3 months, 12 months, and even long term, the Qmax tends to be much better in terms of the figures, around 3.5, whereas in HOLEP or PVP, it's around plus 14. In terms of sexual outcomes, UroLift did not have any compromise for erectile function and no change in IEF-5 score. Resume more or less the same, no change in erectile, doesn't cause ED. And I would say around 2 to 3% of patients may have reduced volume, ejaculatory volume, no change in IEF score. And I have actually found out that some of my patients, they have subjective improvement in terms of sexual function. And hopefully when we do more data, we will know if this is actually being validated well or not. In terms of HOLEP, again, the baseline may not actually change. The orgasm actually may change. The overall satisfaction more or less may stay the same, but the huge problem with HOLEP or PVP is retrograde ejaculation, which can be up to 85%. So let's move to complications. What sort of complications? Most of the complications that I have been seeing with Resume tends to actually, especially the minor.
5 دقائق عشان في discussion بعدين. Okay.
Almost finishing. So Resume tends to have, around 20%, I would say, in the first couple of weeks to 3 weeks. Most of these side effects tend to resolve. According to the RCT, acute urinary retention was developed around 4%. In our data series, the first 23 cases, we did not have actually a real urinary retention, but we're waiting to have more patients to quantify and analyze our data. In terms of acute urinary retention, with HOLEP, it's around 5%. So retreatment, this is very important when we counsel patients as well. With UroLift, there is a huge tendency for symptoms to reoccur, and also the need for further procedure to remove the metals or consider other modalities such as HOLEP or TURP, around 13.5. In Resume so far, up to the 4 years data, the number remained around 4 to 5%. HOLEP tends to have a tendency around 0.5%, and this is mainly because of the regrowth of the adenoma. So what about Kuwait? I thought I'll probably just give you a provisional data. I haven't analyzed everything yet. And we started this in December. We've performed around 23 cases. I left the catheter 7 days because we were worried that if we remove it prematurely, patients will develop retention. So I left it 2 more days just to keep me feel right about it. Majority reported minor complications, Clavian Dandu of 1 to 2. Most common complications that we encountered, dysuria, plus minus urgency, frequency, mild hematuria, around, I would say, 20 to 30%, and most of them resolved completely within 2 weeks. I had one patient, because I kept him on antibiotic longer, and he developed candiduria and with severe UTI, and he could not actually, we did a PVR on him. He was not in retention. He was voiding well, but because of the severe dysuria and candiduria, and in order to optimize his drainage, we reinserted a Foley catheter for 5 days, and then we removed it after he completed his course of antifungal treatment, and he got really well, and he was very happy. In terms of improvement of Qmax and IPSS, 22 of our patients had really significant improvement of Qmax and IPSS. I'm pending to really go over their sheet and analyze these data later on. We had one patient who did not experience any improvement in Qmax, but he was very grateful for the procedure. He said, I'm sleeping really well. I used to, wake up 5 times at night, and now I wake up just 2 to 3 times. And his Badr score changed from 6 out of 6 to 2 out of 6. So this actually make us revise whether we need to rely, go and dissect all the domains of IPSS when we manage our patients, as opposed to have a holistic approach to the IPSS itself. I had no incontinence of these patients, no retrograde ejaculation, no erectile dysfunction. 30% of these patients would just tell me they feel much better in terms of their erectile function, despite no change in IF score that much. And this is just one simple satisfactory photo. This is one of the patients who had, this is his pre-op before Resume, and look at 6 weeks later. This is a huge change in curve, and he was very happy, and his Qmax is around, I would say, 14.2. And his residual volume was here 70, but this patient had previously, his residual volume was way higher than this in a couple of readings. So in terms of advantages, Uroleft tend to have the catheter for 1 day, more or less, and Resume tends to have it 4 to 5 days. HOLEP, you can remove it within 24 hours or earlier. The learning curve for Uroleft is around 5 cases. For Resume, I would say 5 to 10, and I would agree with this. And HOLEP is around 20 and 50, and maybe more to some urologists. And in terms of anesthesia, you can do both Uroleft and Resume under local or general, and HOLEP, you can do it with general or you can do it only with general anesthesia. So let's go finally just to give you a flavor about cost and decision making. So currently no European data that I've seen. In the state, there is one nice study with simulation modeling about the cost and the retreatment and treatment of complications after having TURP or Resume or even Uroleft. And this is a very nice paper published in the Clinical Economics. And the idea is to compare combination therapy versus Resume versus Uroleft versus PVP and versus TURP. And here, this is the way they have put a simulated model, and based on the insurance cost of each modality of treatment, as well as complications and retreatment. And you can see from the study here, they actually quantified whether the patient had early adverse events, how much the cost was for this, and in terms of follow-up, did the patient develop retention, what sort of modalities of retreatment that he had, and UTIs or incontinence or even ED. Because if patients develop ED, it means that this is extra cost on the patient. And that should be taken into consideration in terms of cost effectiveness. And this is more or less, this is a nice conclusion picture for you guys to see. If you compare, for example, green light with Resume, you will see the blue line more effective and more costly for the green light, because on the long run, you would not actually need retreatment. And when you compare Resume with combination therapy, you will see that for Resume, it is more effective and more costly, because these patients will save money on treatment, on a progression of the disease, and getting urinary retention. And when it comes to Uroleft and Resume, Uroleft had less effective and more costly. So it costs around probably, I would say, 7 to 8 times, and in some countries also 10 times the cost of Resume. And because of the retreatment rate, and Resume actually win here. In terms of green light and TURP and green light more or less the same, but you will see that green light tends to be more costly. You will see more blue here as opposed to the TURP part. And when it comes to Resume and combination therapy, look at this curve. So this is less effective, more costly, more effective, and more costly. So this is more advantageous for Resume. Lastly, for TURP and Resume, I don't know if I will be able to convince my colleague, Dr. Hussein and Dr. Ahmed Al-Kandari. I think Resume will be more effective and more costly on the long run because of the low side effects, low adverse events, low cost even for retreatment, as opposed to TURP with all its potential complications over 2 years. As I outlined earlier, the cost of Uroleft is around 3,500 more than the Resume itself, so it's more expensive. And Resume procedure tends to dominates from my point of view. Lastly, I will show you just this slide. Again, let's compare apple with apple, so apples with apples, not apples with oranges. So when we look at the data, we should not compare Resume with TURP. Let's compare Resume with Uroleft or other modalities. So we have medical therapy, MIST, minimal invasive therapies, and definitive therapy such as HOLEP and TURP. And this is another slide that larger prostate, we still rely on simple prostatectomy, whether it is robotically or open. We utilize HOLEP and THOLEP with average prostate. Many modalities are applicable with smaller prostate, less. And finally, this is just my conclusion. We must weigh the efficacy and invasiveness, cost, and the skill. Urolift and Resume, similar efficacy, low complication rate. Resume is more cost effective, less retreatment rate than Urolift when it comes to minimal invasive, and it preserves, both preserve sexual function, and both can be utilized for prostate less than 80. PVP and HOLEP, higher efficacy and lower treatment rate. And lastly, they can be used for any prostate size. Thank you very much. I apologize for Dr. Ahmed Al-Kandari. Thank you for giving me another 5 minutes extra.
No, I wish I can give you all, thank you very much, Dr. Ahmed, for this excellent and thorough talk. I wish I can give everybody the time. It's just, I know our colleagues gave suggestions that we can stay longer, but I'm just trying to make it more attractive. If you take long, you lose concentration. So I'll just take a few questions from the audience, and I'll go with you with the panel about a few cases. Dr. Kamran, there was a question from the audience. Can you combine 2 alpha blockers if the patient does not respond to 1 alpha blocker? Can you combine 2 alpha blockers, and can you give like extra maximum dose off label to improve obstructive symptoms with alpha blockers? Do you hear me, Dr. Kamran? Your voice? Okay. Did you hear the question?
Yeah, I heard the question. Sorry, I just unmuted that. So alpha blockers, depends on which kind of alpha blocker is being considered. I'm not sure in Middle East, I mean in Kuwait, what alpha blocker you prefer.
We commonly have this tamsulosin, alfuzosin, and also psilocin or rapiflow, like they have in the States. So these are the 3 common.
Sure.
So the doxazosin is out of favor. Tirazosin, like they're not available anymore. Okay.
So, I mean, tamsulosin, I have seen some people, specifically general practitioners, because the way how the UK system works, they go through the general practitioner, then come to the hospital. Sometimes they have given patients off-label or just like a dose that's an additional dose, but it doesn't work. It results in more side effects. Same with non-selective alpha blockers. They will definitely result in increased side effects, and that can affect, that can have cardiovascular effects. So now the answer to this question is, it's not been used, not been tried. There's no evidence that I at least know. I mean, I've seen the literature recently as well. So the answer is no.
Yeah. Okay, well, I have anecdotal cases. Patients tried and they said they improved. So I tell them, well, if you have no side effects, just you continue. But you're right, there is no evidence to prove that. The second question from the audience to Dr. Ahmed Al-Nizi. Dr. Ahmed, is there a limit? You mentioned that size for Resume. And can you do Resume on patients who are anticoagulated, like on warfarin, for example?
Excellent question. Yes, you can. You can use it actually. This is one of the beautiful procedures that you can use in patients with anticoagulation. I tend to liaise with the hematologist, and also if I can bridge them, I would. But I have actually attempted one case where I actually omitted just warfarin for a couple of days with the recommendation of our hematologist, and we managed actually to do a couple of cases, and they, you know, things went uneventfully. In terms of the limit of the size of the prostates, I'm sticking by the guidelines because we are still very early on in Kuwait, and I'm very strict in following the guidelines. I've been pushed to even asked to get patients with urinary retention to be done, and some of them are very educational. They went to Google and said, look, in the States they are doing
yes. So the sound alleg. Dr. Ahmed?
I think his connection is
still very early on. We have to be very...
Okay.
Can you hear me?
Yes, yes. Okay, so are you? Yes, go ahead. You finished?
Did you hear my answers?
Yeah, it was interrupted at the end. So your upper limit of size is 80, as you mentioned. Is that right?
Correct. We're going up to 80 at the moment, more than 30 and up to 80. And
the middle lobe is not like exclusion for Resume?
No, median lobe is not an exclusion. They tend to do well, actually, these patients.
Okay.
Because they tend to have, they tend to be very
from Urolift.
Yeah.
Yeah, in Urolift, some surgeons, they were resecting the middle lobe and then putting Urolift laterally. They said their middle lobe, site is not very reliable. I think I will go to the quick case discussion. Can we change the slide, Dr. Hussein?
Dr. Ahmed can actually stop sharing.
Yeah, let's just do that.
محمد فوق
Yeah.
عندك. Up on the screen, like you'll see red in the middle of the screen says stop sharing. I think you stopped sharing already.
I think so.
Yeah.
No.
Mohammed, you can start sharing. Dr. Ahmed Kennedy.
زين أنا أفتح هذا ها.
Yeah.
I have very few 4 cases discussion for the panel. Now.
Just we have to bear in mind that Dr. Kamran has iftar. I'm not sure how.
لا خلاص. How much time he has, Dr. Kamran?
That's okay. I mean, we've got about 15 minutes. So that's
okay. No. We'll give you the question and then you can have iftar and make dua for us. How do I, Abu Ali, Turkey, how do I share? Just
so share? You just move your mouse to the bottom of the screen. There will be a share screen.
Okay.
Press it. Then choose your PowerPoint. Yeah.
Okay. So these are quick cases. We'll go for the first case. So this is 58-year-old. These are real cases. This one is a real case. 58-year-old male who came to me with obstructive voiding symptoms since 4 years. His Qmax was 9 ml per second. His post-void is not significant, like 40, 50, but the patient is very symptomatic. Like he's taking steps every 1 hour. He's going to the bathroom, straining, waiting. He's like, anyway, his prostate on ultrasound, abdominal ultrasound was 40 ml. There was no obvious middle lobe, which I think is interesting to follow and see. The patient he refuses medical therapy. He's otherwise healthy. He only has hypertension. He used Zetral, which is alfuzosin, and then he stopped it because he had severe dizziness. He could like fall down. So now he comes to you, Dr. Kamran, before you go to iftar. Doctor, I'm very irritated. I cannot empty. I'm going frequently. And you told me the prostate can be managed medically. So can you change it to another medication, or would you give me any of the advices like the other colleagues mentioned, like Urolift, Resume, TURP? So he has no trials except for one single time of severe dizziness with alfuzosin, and he he freaked out of this medication. He said, I can't live like this.
I mean, this is, he's relatively younger person. He's 58 years old. I mean, before considering any kind of intervention, I mean, I would just would like to give him all the details regarding the side effects related to the intervention.
Okay.
And I think this is a person who falls within the category of a trial of second-line treatment if the first-line alpha blocker is not working. I mean, this is someone who can benefit from 5-alpha reductase inhibitors as well, so which has not been tried in this person. So I would try to just talk to him about that.
Okay.
If he agree.
He's very symptomatic, and he was told like this will take time to be effective. So
yeah, if he doesn't agree, then I think the other option is specifically this a relatively new treatment, especially in a 58-year-old person. Resume, no option about that. I mean, it's like a enlarged prostate and no middle lobe, lateral lobes are there. Resume still effective in the lateral lobe within 6 weeks, 4 to 6 weeks. The outcomes can be seen in this kind of patient if it's available. Other options if he's going to go ahead with the intervention, just like other interventions have to be discussed then.
Okay, because of Corona, this is a real case, and the hospitals are refusing to admit cases unless it's emergency. So you told him, I cannot do surgery for you. So then he asked me, can you give me another treatment which may help? Have you tried changing alpha blockers when they have side effects and you still can get away with the side effects?
I mean, alpha blocker, obviously tamsulosin can be tried. I mean, we can certainly we have tried it, but most of the time with the alpha blockers, if one alpha blocker, I mean, Zetral is an alpha blocker, that's just obviously it's alfuzosin. I mean, it has got a wider spectrum than tamsulosin. And most of the time, in my experience, changing the alpha blockers, it doesn't always work. So it just gives, I mean, although they are quick to work, I mean, within days, patients notice the symptoms, but most of the time, I mean, whenever I'm doing a general clinic, I mean, these patients actually do not get benefit out of it. So Yeah, I mean, that's in short my answer. Mostly
Okay.
get benefit by changing or switching it.
Okay. Well, actually, because we could not operate, I gave him Omnic. I did cystoscopy for him because I was just make sure he doesn't have a stricture or anything else. And he does not have a large middle lobe as proven with ultrasound cystoscopically. He's like a small size prostate, or medium to small size. And he's feeling mild improvement, and we'll see how it goes. Yes, Dr. Hussein.
So if you allow me, Dr. Al-Kendri, I will comment on this. So I think it's all about expectations here. If this patient had dizziness with Zetral, that does not mean he did not respond well in terms of avoiding symptoms to the alpha blocker. Yes. So I think he deserves another alpha blocker. If we look at the side effect and the safety of the medications that we're using for BPH management, Zetral is actually more safer than Omnic or the tamsulosin in terms of hypotension. So if I want to change from Zetral, my personal option would not probably be tamsulosin. I might use actually the newer medication, which is psilocin or psilocin, because that is super selective. The risk of having hypotension with the psilocin might be less than all others. The problem with psilocin, as we all know, is the retrograde ejaculation. So once I explained to the patient well that he might have a 25% risk of having a retrograde ejaculation, if he accepts that, then I think that would be my best option of treating this patient. What if he does not respond? And you said you scope this patient and he has a small prostate with no median lobe.
Yes.
I don't know.
Like, as we call it, obstructive, although this is not objectively true, but it looks like obstructive prostate. I was just willing to rule out any other cause for his obstructive symptoms like a stricture, etc. Yes, go ahead.
Exactly. So what from this, if we look at the literature and if we look at I've talked about Resume and Urolift, about this category of patients to the experts on those minimal invasive procedures, and actually they don't do well with those minimal invasive procedures, because with Resume they might miss some of the spots, and they might actually have some kind of fibrosis in the bladder neck if you treat aggressively the bladder neck. So I think in this category of patients with a small, very small prostate, bladder neck incision is a very quick procedure. The morbidity is very low. It's lower than the conventional TURP, and they do very, very well after that. Actually, most of the patients, they avoid like never they've done in their life. So
Dr. Ahmed Anizi, do you agree? And you should avoid in a small size prostate, or you be careful at least about bladder neck problems?
I would agree with everything that was said, but my only concern about this patient, first of all, whether we need to have his IPSS done. We need to know his SHIM score, IEF-5 score, and I would like to know his PSA. That's for sure. Before
PSA is below 1.
Below 1.
SHIM score was not done.
I would like to know his post-void residual.
Was around 40, 50.
And another reading for uroflowmetry, apart from just relying on one reading. And then having said that, different modalities are, once I'm sure that this patient is just fitting the criteria of BPH, I would like to know if he has completed his family. Even with
he has completed his family.
Correct. Even with TUIP, you still have a margin of retrograde ejaculation and reduction in seminal volume. Okay. So my other options would be between Resume and Urolift, depending on the skills that I have. I haven't been trained on Urolift, and I'm not even a fan of it based on the literature that I've seen lately. So I would offer him between TURP or Resume, and even laser treatment such as green laser or HOLIP.
Yeah, I mean, with the laser treatment, the issue is it not that for the smaller prostate, because depending on the intensity of there's a more risk of stricture.
Yes, correct. Having said that, still you can offer you can offer laser treatments, especially green laser, like vaporization for prostate around 40. So my option with these patients, if I ruled out everything else, I would probably go for resume or TURP.
Okay. Because Dr. Kamran is in a rush to hope iftar, this is the last case for you, Dr. Kamran. A 70-year-old male with LUTS and BPH since 5 years. He was on medical treatment. He came to you in the emergency with a first-time acute urine retention. The registrar put a catheter. They drained 1.5 liters. They did an ultrasound. It's a large prostate, 150 ml prostate with large middle lobe. The treatment options. Would you consider, since this is the first time retention, you would drain him and put him on a trial of medical therapy, or you will shift to surgery? What is your advice on that?
I mean, this is a good question, and then I mean, we don't see we see these kind of patients very often, and the evidence that's there around the treatment, whether we consider treatment or intervention below 1 liter or above 1 liter, it's all changing. So, I mean, it's a 70-year-old man. I would like to know what is his first expectation out of this, and what is his quality of life, what is his comorbidities like. If he's really a fit man and without any problems, independent, then we would like to keep his or maintain his quality of life. I mean, the most important things here, we are looking at 1.5 liter stretch bladder with the actin and myosin fibers totally stretched out, and there's no capacity for them to go back. So, I mean, if he's a fit person, then I would consider some kind of intervention. A trial can be discussed depending on what the residual volume in future would be like, or if he's got ability to do self-catheterization. These are the options that could be discussed. But the options of intervention is more likely in this kind of person with 150 ml of prostate and 1.5 liter of bladder residual volume. So different options are there. This 150 cc prostate could be, I mean, a laser procedure regarding the prostate, could be a green light or a HOLEP. HOLEP is a more satisfying procedure, or green light burns everything out. So both have similar kind of outcomes depending on the availability. I mean, we do both. Yeah, so just like, I think intervention is more likely that this person would be heading off to, but also depends, as I said, comorbidities, his renal functions, and a renal tract ultrasound scan would be required. And instead of ultrasound scan of the prostate, I would like to get this person to have an MRI of the prostate, because that gives us more actual reading in a prostate that's 150 cc.
Okay. What about the timing of intervention? Would you wait a week, 2 weeks? And some people, like if you are above 2 liters, do you see a role for urodynamics? I have it in the next case, or you just go ahead and do the intervention and hope his bladder will recover?
I mean, with the timing, we don't do procedures straight away here, the way how the nature of the system is like, healthcare system here. They usually wait about 6 to 8 weeks or up to 3 months sometimes. Okay. But if there is an option, I mean, timing, I would wait at least for 4 weeks in this kind of patient. With regards to the urodynamics, I mean, there is a varying school of thought. Some people say that above 80 is required, above 70, he's borderline. So urodynamics can be considered. But again, this is something that's another added intervention that would give us a picture of obstruction, or it may give us a picture of overactivity of the bladder. Because this man is 70, he will certainly have some degree of overactivity of the bladder. So urodynamics, not mandatory, not necessary, but if it's still, I mean, discussion takes place, and then, okay, we are got waiting time to see, I mean, there's a waiting time for this patient, I would get this patient to have urodynamics, otherwise it's not necessary.
Okay. Dr. Hussein Anizi, would you do TURP if you are an excellent surgeon, and let's say you don't want to do robotic, I know you are a robotic surgeon, but can you encourage, if you are a quick resectionist and you can have a bipolar system and you can limit yourself, let's say 1 hour, 1.5 hour maximum, and you monitor the patient well, would you do TURP for this patient?
So for the patient with a 150 grams prostate, it's I think it's huge for a TURP, even with a bipolar. The problem is, well, we don't have the TR syndrome in TURP because we're using saline, but still fluid absorption might be a problem.
Yes,
so yeah, overflow. So I think we should not, still with the bipolar TRP, we should not extend the time of the procedure. Maximum 2 hours, we should be finished with the TRP, especially if this patient has a comorbidities. I think for a 150, no, it's a HOLIB. If someone is well trained in doing HOLIBs and they can finish this procedure well, or maybe another procedures that can inoculate the prostate. Like now, more people are trained on doing well, bipolar inoculation of the prostate. That might be another option. In my hands, I would do a robotic simple prostatectomy for this patient. And they do very well after that. I think those are the options. TRP might not be the option. I know that some surgeons would say, let's do one loop and finish and do another loop at that time. But that's 2 sessions instead of doing 1 session. I don't think that's very fair for the sake of the patient.
Dr. Hussein, Dr. Ahmed Lanizi, resume not for this size, huh? You agree?
No.
Okay.
But having said that, there are now some preliminary data that you may actually offer
at stage to resume
limitations.
Okay.
I wouldn't offer it at the moment. No.
Okay. I have 2 more cases. We'll finish quickly. Case number 3, 60-year-old male has frequency, urgency, urge incontinence. His urine flow Qmax is 10 ml. Post-void, he has 100 ml. Prostate 60 gram. Dr. Kamran, this patient came to you. He's very symptomatic. He has frequency, urgency, but his still flow is weak. He's bothered by these urgency symptoms. So what are your treatment options? Would you give him tamsulosin and sulfenacin? Would you do urodynamics and cystoscopy and decide? Or would you operate? Or how do you proceed?
He's 60. He's got frequency and urgency, degree of urge incontinence. I mean, how do we know that it's not an overflow incontinence? That's another question. I think I would like to look at the full IPSS score. And urine Qmax is 10, which is moderate for this age group. I mean, below normal. I think the first question is that instead of tamsulosin and sulfenacin, this guy is 60. In order to avoid the side effects, I may consider just like a trial of tamsulosin first, because with the tamsulosin, you can tell straight away whether these people respond or not.
Okay.
Depending on if the renal functions are normal, then tamsulosin may well work in this person. And because tamsulosin, it does not change the it does not limit the progression, but improve the symptoms. If the symptoms are improved, in the next few years, he may need some addition of medical treatment or may move or drift towards the surgical option. So tamsulosin may work.
Okay.
In this person. I would give a trial of tamsulosin. It may work.
Let's consider he received tamsulosin and he did not improve. You added sulfenacin, then he was getting more residual urine and he's still symptomatic, frequency, urgency, urge incontinence. He has weak flow, but he's more bothered by this urgency and urge incontinence. So would you do your dynamics at that stage?
If we tried both of them, then this guy is 60. I mean, there's a borderline indication for urodynamics, but I mean, in my practice, we do urodynamics a lot. I would definitely consider a urodynamics in this person who's 60 years old, fit and well, no other medical problems, before deciding on any kind of further treatment.
Okay, so we did urodynamics. That's considered it's done, and it shows that he's obstructed with an element of active bladder. So now, what's your procedure of choice?
If then I would like to know what is his prostate is like, whether if there's kind of lateral or medial lobes. Or,
mainly lateral lobes, no middle lobe.
I mean, mainly with the lateral lobes, I mean, Resume could be an option for this person as well. I mean, this is a new treatment. It's very effective, day case treatment, or a bipolar TURP. And but we have got here at King's mostly it's a green light or Resume. But the bipolar TURP, depending on the lobe, whatever the expertise there. I have never tried Urolift myself, but all options apply to this person. There's no question about it.
Dr. Ahmed Anizi, will you do Resume immediately after he fails medical treatment and he's obstructed? Do you think it's a good option for relieving obstruction?
I think it's better to do urodynamic and cystoscopy on these patients. That's for sure.
You did urodynamics. He's obstructed. He has high pressure with low void, with low Qmax. and overactive bladder element as well. And his cystoscopy shows obstructive looking lateral lobes. Let's consider that.
Absolutely. Then you may actually offer him with whether his prostate is 60, so you can offer him. But this patient may actually remains.
Yeah, he is bothered by irritative symptoms. He's obstructive. Would you worry that he get worse initially, the first few months?
He has to be counseled that some of his irritative symptoms may persist, and he may actually need other alternative treatments for that.
This is very important. Okay.
Yeah. So you know, addressing patient's concern. So we might be solving his obstructive part, but it might take time for his irritative or the storage symptoms to come back.
Dr. Hussein, I think this is a straightforward case for resident TURP. Is that right?
Yes, but it's not straightforward for the consultant because those patients, I tend to be very careful with those patients who are actually more bothered by irritative symptoms or storage symptoms more than voiding symptoms.
You have a good urodynamics that he has high residual, 100, and he has a high pressure voiding. And he has, as you said, you're absolutely right. He may need, as Dr. Ahmed said, he may need further treatment for his bladder if he does not settle down by time.
Yes, this is why when counseling those patients, I will certainly tell them that there's a probably 20 to 30% chance of their symptoms persisting after the TURP or whatever. I think he's a candidate for any other alternative procedures. Will it be resume or urolift or any other kind of procedure for BPH? But the problem is post-operative. Will this patient have his irritative symptoms resolved or not? I tend to tell them that they might still need medications or further treatments for their bladder after the solving their obstructive symptoms or obstructive problems.
Absolutely, absolutely right. The final case, Dr. Kamran, this is you're free now. A 45-year-old male with BPH. This guy is young. He has obstructive voiding symptoms since he was 18. Weak flow frequency. He was on medical treatment for the last 10 years. His Qmax is low, 8 ml per second. He has a high post-void residual 100. He's married. He has children. He does not need any more children. He has 5 children. As you know, in Kuwait, they like more children. His prostate is around 50 ml with large middle lobe. The patient still does not want to lose ejaculation. He failed medical therapy. He used all the alpha blockers. He did not want to use 5-alpha reductase inhibitors. He's worried about sexual side effects. He's sexually active. So he said, doctor, I'm here for you. Can you do something as a procedure to relieve my symptoms and I will still preserve my ejaculation? Because he may get a second marriage and some of them, they want children. So what do you advise them?
He's 45 and it's been 10 years for this treatment. That's that's very unusual. But still, these are one of these kind of cases do come up. I think that first of all, I would like to see the urodynamics evaluation of his lower urinary tract. So see what exactly it is like. And because obviously there needs to be an objective evidence in order to prove the obstruction in a young person. That's like an absolute indication for urodynamics, no question. If depending on everything else, whether it's okay in terms of his renal tract, his renal functions, ejaculation preservation surgery, endoscopic surgery, there are a number of options. Even Dr. San Naisi just mentioned in his talk that there are TURPs, so that we do green light ejaculation preserving as well. And to some extent, resume is, be reported as depending on where you put in the steam as ejaculation preserving option. So there are various options for him. In view of the new evidence and newer modality of resume, which is showing promising. This could be one of the options for him for management. But obviously he needs to know that all these options are not foolproof. He will still have some degree of retrograde ejaculation. And if he's still looking for children or having more children, then his option, if he goes ahead and is not successful in terms of preserving ejaculation, could be IVF.
Yes. Dr. Hussein, do you want to add something?
Yeah, can I comment on this and correct me if I'm wrong, please? I think the only procedure that is proven to preserve ejaculation 100% of cases is urolift so far. Even with resume, there is a chance, like 5% chance of losing antegrade ejaculation. So if this patient is very particular and he did ask about a procedure that would preserve his ejaculation for sure, or the most successful in preserving his ejaculation, I think UroLift is the best option for this patient. However, the problem is the large middle lobe. I know that some experts might actually like apply some UroLift there, but this needs an expert to do it who had multiple procedures done. Otherwise, treating this patient might not be actually successful. The other comment that since you mentioned that this patient has been suffering for a long time and for probably long years of his life, I want to comment on something that unfortunately most of those patients, they are diagnosed with chronic prostatitis, although they might had a problem with the bladder neck, and they typically those patients have visited so many doctors in the past. So please, if you have a patient with the symptoms of chronic prostatitis, pay attention to the fact that you ask about the urine flow and uroflowmetry. A simple test like a uroflowmetry might actually indicate that this patient has a genuine problem, not only chronic prostatitis symptoms with pain. So we tend to miss lots of those patients without treating them properly. That's my comment.
Dr. Ahmed, do you want to add something?
I would just
resume for this patient. He has middle lobe, 50 gram.
I agree with both of you. This patient will need cystoscopy, will need urodynamic. We need to make sure he does not have chronic pelvic pain syndrome. That's for sure. These kind of patients will do worse with minimal invasive, whether it's UroLift or even with resume. The implications would be even higher, and patients would not be addressed. You know, the concerns would not have been addressed really well.
Okay, this concludes our webinar. I would like to thank Kuwait Urological Association for this great opportunity, and thanks to Dr. Hussein Al-Naji, Dr. Mustafa Al-Mahmoud, Dr. Abdel Nasser Said, the chairman, and also our great thanks to our colleague from UK, Mr. Kamran Ahmed, for your great time and talk. And we really enjoyed your talk, and we hope to see you soon in our next webinars or even after the corona is over. And also thanks to Dr. Hussein Al-Naji and Dr. Ahmed Al-Naji, and thank you very much. And I hope I was a good moderator and things went very well. Thank you so much.
Thank you.
Thank you very much. Thank you very much.